So why don't we start? We already have close to 300 people. We're expecting maybe a couple hundred more. My name is Bill Friedheim. I'm chair of the PSC Retirees Chapter. And I think, as everybody knows, today's meeting is focusing on healthcare. Healthcare writ large for retirees, but also healthcare writ, I guess, smaller, very immediate, in that we're all concerned about what happens between now and October 31st, when we either have to opt in or opt out to the Medicare Advantage plan, or opt out and stay on our traditional Medicare plan. So before, we're going to start the meeting with two speakers, Barbara Caress and Barbara Katz-Rothman, who I'll introduce momentarily. But before I do that, I want to ask Dave Kotelchuk from our Retirees Executive Committee to speak just for a moment or two about an upcoming event discussing the book, The Sum of Us. So Dave?
Right, good. Okay, thank you very much. Now, I'll be brief. We are going to open the book series of the anti-racism, sponsored by the Anti-Racism Committee, on The Sum of Us All, what racism costs everyone and how we can prosper together. Look, folks, there are literally hundreds of fine books about racism in the US. The histories of Eric Foner from the 19th century, the histories by people like Brian Stevenson, Michelle Alexander, Isabel Wilkerson, and then we have, the great authors, James Baldwin and others, novelists. So why are we choosing for our book series, The Sum of Us All by Heather McGhee? First, Miss McGhee is a fine, accessible writer. But foremost, we believe The Sum of Us All covers many different arenas of American life: housing, education, voting rights, environmental justice, climate change, and how racism negatively impacts the lives not only of African Americans, but the lives of us all. In so doing, in doing so, McGhee draws upon some of the best writing and research of others in these arenas, and introduces her own perspectives with the by now famous image of the closing of public swimming pools to all in the 1960s, 70s, and 80s, and its impact on our lives today. We are going to have our first meeting, first organizing and discussion next Tuesday, October 12th at 2 p.m., followed by 4 more Tuesday afternoon meetings during October and November. Our second meeting on October 19th will be about racism and housing, with a brief introduction by our own Tom and Gotti. But let me remind you, this is not going to be a lecture series, but a series of book discussions among colleagues and friends. That's why we are limiting registration to 25 members. But I'm happy to announce we still have openings for registration. So we will still be welcoming registrations this week. Please consider joining us. If you have registered already, I sent you a Zoom invitation this morning. If you register during this week, we'll send you a Zoom invitation later in the week. The reading for next week, as you prepare, is chapters 1 and 2, 39 pages, first 39 pages of the book. Thank you, and please join us next week. Goodbye.
Yeah, an important book, an interesting discussion. Hopefully people join. I put the link to sign up in the chat. Couple of other housekeeping matters. One, there are a number of people on this Zoom call who are not members of the Retirees Chapter. You're certainly welcome, but we would like you to encourage you to join. If you are already a member and have not re-upped for the 2021-2022 academic year, please do so. If you want to find out more about the Retirees chapter, we're going to put the links in the chat to sign up as a first-time dues member, to renew, and we'll put the link in the webpage where you can find out more about us. Just quickly, a couple of upcoming events. As all of you probably saw in the recent 2 email blasts, on October 20th, we're going to have a discussion of the controversial resolutions that the PSC Delegate Assembly passed last June on Palestine and Israel. I'll be sending out an email blast later this week, again next week, for the discussion that we're going to have at 1 p.m. on Wednesday, October 20th. To join the discussion, you must be a member. We'll have the link to register in that email blast, the email blast later this week and the email blast next week. By the way, you are a member, even if you haven't re-upped for this year, through the end of October. There is a grace period for paying your dues. We keep all members on through September and October. Let me just also note that on Monday, November 1st will be our next regular chapter meeting at 1 p.m. We have a number of really interesting speakers, who will talk to us about policing and alternatives to policing. And then in December, on Monday, December 6th at 1 p.m., we're going to have our December chapter meeting, and the focus there will be the new political landscape for us here in New York City and in New York State. We're about to get a new mayor. And of course, as everybody knows, we now have a new governor, and this opens up all sorts of interesting possibilities in terms of funding for CUNY, in terms of the issues that the professional staff Congress considers really important. So hopefully you'll join us for those meetings. All right, on to today, healthcare. Let me introduce 2 speakers. After that, we'll open it up to questions and answers and discussion. And then after that, as promised, there'll be an information session on navigating this retiree healthcare system as we have to make decisions between now and October 31st. So our first speaker is going to be Barbara Caress, who will speak on the history of Medicare and Medicare Advantage programs with a particular focus on the New York City plan. She's going to talk about the plan that we're being asked to join or to opt out of, depending on what we decided. So Barbara Caress has more than 40 years of experience as a union, nonprofit, and public agency manager, consultant, and administrator. Presently, she's teaching public health care policy at both Sarah Lawrence College in the graduate program and at Baruch College. And very importantly, she's been hired as a consultant by the PSC to help us navigate issues, the issues of retiree health care that confront us. And then Barbara Katz-Rothman, a professor of sociology at the CUNY Graduate Center and at Baruch College, will then comment. She's a recipient of the Jesse Bernard Award of the American Sociological Association and Distinguished Chair in Health Sciences from the Fulbright Association. Her most recent book, published this year by Stanford University Press, is The Biomedical Empire: Lessons Learned from the COVID-19 Pandemic. So Barbara Caress will speak first. She's going to share her screen and do a PowerPoint. She'll raise some important questions for us. Then Barbara Katz-Rothman will speak after her. And by the way, Barbara Katz-Rothman, together with a member of our retiree EC, Eileen Moran, has an article in the October Clarion, which if you haven't gotten already, hopefully you'll be getting a hard copy this week, and it'll be posted online in a day or two. So Barbara Caress, you're on.
Okay, thanks. And thanks, Bill. Let me put the screen share up. Okay. It's asking me if I want to share with everybody, and I think the answer is no, since there are 500 of us. But so this is a 10,000 foot view of the Medicare Advantage plan that you're all struggling with. So it's, I do formulate a couple of questions that you might want to ask yourself, but this PowerPoint is really intended to put what you're dealing with in perspective. So, and basically you have to make a choice. I think everybody knows this, but let me just repeat it. So you have a new plan called the New York City Advantage Plus PPO, which is replacing, if you don't opt out, it will replace your Medicare Parts A and B with a Medicare Advantage plan sponsored by Emblem GHI and Empire Blue Cross. And its terms are pretty simple. After a $253 deductible, meaning you have to first spend that money out of pocket, you'll then be entitled to go to seek your medical care with some modest copays, and basically it will cover all your out-of-pocket costs. The alternative is to pay about $190 a month to the city to retain your current senior care plan, which is a supplement to Medicare. It's a plan you've had all along. It also now has a deductible of $253 and some copays. So that's the choice. And let me move on. And this is essentially my short presentation, speaking to 5 points, put it in context, looking at the comparison between what the city spent in 2021 and what it expects to spend in 2022. What are the open questions? A couple of questions I think you might want to ask yourself, and then a final slide which says Medicare is forever, and I'll explain when I get there. So the initial point is that Medicare is an American health plan. Very important thing to remember. And it was built on the system that we had. And 2 essential points about it. One was it was conceptualized to pay whatever costs the providers charged within some constraints, but essentially what they charged was what the government would pay. And secondly, that decisions about healthcare services and the administration of healthcare services would be in the hands of the health system, not the government. So it was born with anti-regulatory language, which are basically the first 2 amendments to the Social Security Act that was adopted in 1965. What they didn't reckon with was demand, inflation, and greed. So they made an assumption, the actuaries to the House Ways and Means Committee made an assumption in 1965 that Medicare costs would increase from about 3.4 billion when the plan first came into effect in 1966, and it would hit about 12 billion in 1990. And they were way off. They were off by a factor of 10. In 1972, they made amendments to the Social Security Act to try and deal in part with some amendments expanding Medicare, but there were also amendments trying to deal with this very unexpected balloon in cost. And a couple of people, it wasn't a widely held notion, thought that maybe what we should do is have the private sector, have private insurance companies, which at that time were also struggling with inflation, come in and see if they can help manage the increase in cost. That's the beginning of what we now know as Medicare Advantage. It didn't work. And this chart shows you the bottom line is zero. The bottom line says that if the costs, comparable costs between Medicare and Medicare Advantage were held constant, there would be a straight line on the zero, on this axis, on the horizontal axis. And you could see that wasn't the case. It increased, it reached a peak of about 16%, costing the federal government about Medicare Advantage costing the federal government about 16% more right before the ACA than Medicare, traditional Medicare for comparable recipients. ACA significantly cut the subsidy that was paid to the Medicare Advantage plans, and you could see that it was quite successful. You could see the peak, and then it comes down on the other side of the curve, and it's inching up a little bit now, which is of some concern to the federal policy people, the people who make Medicare policy, MedPAC. Medicare Advantage was created with two objectives, and first was to save money, and it didn't. And secondly, to make it so attractive that people would voluntarily agree to have their benefits regulated. If you go back to the initial idea, when all of the power was left in the hands of the health system, Medicare Advantage is run by commercial insurance companies, and it imposes some different kinds of regulation into the system. And so the theory was, we can get more people to voluntarily come into Medicare Advantage, we can have some price controls, cost controls, and by making Medicare Advantage an attractive option to Medicare retirees. And as you can see from this chart, we've reached now about 40% of all retirees have, in fact, opted into Medicare Advantage, and significantly 50% of the retirees whose benefits come from their employer or union are now in the Medicare Advantage plan. And how did they make it more successful? They basically Medicare Advantage fills many of the gaps left by Medicare. And it's important to know that Medicare is a wonderful program. However, it leaves a lot on the table for people to pay out of pocket. On average, people 65 and over spend 12% of their disposable income on healthcare. And that has two elements: Medicare cost sharing, because the original Medicare still has very significant cost sharing, deductibles, co-insurance. And the second part is the services that are not covered by Medicare, including dental, vision, hearing, and most expensively, long-term care. So this 12%, the orange represents people's out-of-pocket costs to meet the Medicare cost share, and the blue represents the services that are not covered by Medicare. Medicare Advantage basically fills the orange and a bit of the blue. Let me just talk about the underlying idea and then examine it in our context. So the basic theory of the Medicare Advantage, and it's codified in changes to Social Security Act in 1996, 2004, and 2010. The idea was, by creating managed networks and rewarding quality, all of this is in parentheses because I'll explain what they mean. Medicare plans presumably Medicare plans reduce the cost of care, and simultaneously retirees are given access to comprehensive, high quality primary and preventive services. And it's based on a theory that good medical care management leads to fewer big ticket services like inpatient care and high-tech imaging. Unfortunately, really important fact, the literature shows that that doesn't work. Actually, that managing healthcare does not lead to cheaper care. It sometimes leads to better care. but it rarely reduces the cost. So the theory of management, which prevails and dominates the notion of the Medicare Advantage, actually turns out not to be right. It was a good theory 20 years ago. It's no longer applicable. So since the theoretical savings aren't likely, Medicare Advantage insurers find other ways to cut costs or to increase their payments from CMS. Typically, Medicare Advantage plans, let me say before I start this, that the Medicare Advantage plans are the payments from the government, from the federal government, from CMS are pegged at the average spending of traditional Medicare recipients in a community, in a county or a region. So they start off with a number that's roughly applicable to both the Medicare Advantage and the traditional Medicare. And so the question is, how does an insurance company being paid the same amount that's paid for other Medicare recipients manage to cut costs or make money? And they essentially do it in two ways. One is by reimbursing hospitals. They reimburse hospitals about the same amount as Medicare, and you'll find that the Medicare Advantage plans and the traditional Medicare have networks of hospitals that are roughly comparable. On average, Medicare actually pays more for ancillary services like labs and x-rays. Medicare Advantage plans use commercial insurance rates, which are lower than Medicare. But most importantly, Medicare Advantage plans organize networks. If anybody has had employer-based coverage, you typically have a PPO, a network plan. So Medicare Advantage plans depend upon the organizing networks where they promise the providers quick payments and market share in return for somewhat lower payment. They, on average, pay the doctors in the Medicare Advantage plans less than doctors are paid by commercial insurance. That's one way they cut their costs. And the second is they require pre-authorization for expensive services, inpatient, high-tech imaging, rehab, OT, PT, etc. And not that those services are frequently denied, they're not. But the fact of seeking approval gets people to think twice. And when you think twice about something, you see a long line, you say, well, I don't really need that. And that happens in a lot of provider offices. And third, and the last part of the way that the insurers make do with what they're given is that there are ways to increase the rate above what traditional Medicare would have paid in those communities. And there are two mechanisms for that. One is through getting high quality ratings, and I'll talk a little bit about that later. And secondly is with a risk adjustment factor. So if the population in the Medicare Advantage plan is sicker on average or older on average than the traditional Medicare, CMS will give them a little bit more money. And insurance companies are very good at coding up their participants. Has nothing to do with whether they're sicker or not sicker, but they do manage often to secure more money. So how can Medicare Advantage be cheaper than Medicare? And I think I've answered this question. The secret sauce is networks. And I just put up here the networks that are part of Emblem and Empire. So as you can see, Empire has 4 separate networks. Emblem sponsors 3 separate networks. And what's important to know about these networks is that the rates that they negotiate with the providers, hospitals, doctors, ancillary services, are different in different networks. So the differentiation from network to network. So the size of where they pay the most, where the insurance companies pays the most, correlates with the largest networks. Where they pay the least, and typically that's Medicaid plans, the networks are smaller because fewer providers are willing to accept lower payments. This is pretty simple. This is a key and important element in understanding your plan. So I've done a very, very gross, as I said, 10,000 foot analysis of what the city would be spending in 2022 compared to what it is spending in 2021 for retiree health benefits. And you could see it in 2021, it's $1.1 billion. It's a lot of money. About a third of it is the Part B reimbursement. And that's not in question at the moment. So what I've done is to estimate what they would spend in 2022 if 90% of the enrollees are in the Medicare Advantage plan and 10% opt out. And net is $605 million. I call this what we don't, there are many things we don't know yet. And I know we need to know, you need to know before you make your decision. And it's hard to know them because they will be, the answers to these questions are shrouded by the contract negotiations, which are not public. So my first question is, they are promising you that you can get care from any Medicare participating doctor. And they have offered unlimited out-of-network, in-network or out-of-network, from the perspective of the retiree. There's no difference in your out-of-pocket costs. And I'm wondering, given what we know about how Medicare Advantage plans work, how they could possibly afford that. And I asked, what are the contractual escape clauses? What is, if it turns out that this is more expensive than they estimate, what's going to happen in year 2, 3, 4, or 5? We don't know. And what networks will they be using? I think we have an answer now that in the city, according to the Emblem website, the network will be Emblem's GHI network, and outside of the city, it will be Blue Cross's or Anthem's Medicare PPO network. The third, and this is a tough one because no PPO that I know of can make this promise, but the promise is, what guarantee will there be that once a doctor or a hospital is listed in the directory or the online directory, that they will still be in network at the end of the year? What is the contract and what will the contract between the city and the alliance provide? Will it have language that says, even if a provider opts out before the end of the contract period, the insurance company is committed to covering the retiree's costs? So those are 3 open questions that will be answered by the contract, but we can't see it. The contract is not likely to be completed until after the 1st of January. They'll operate, if they start on January 1st, they'll operate on an MOU with a contract to come later. And here are some questions I thought you might want to ask yourself. And it's important to know you can opt out once a year. So every year you'll have, if you're in the Medicare Advantage plan, you'll have an opportunity to switch to senior care and pay the premium, or vice versa. If you're in senior care, you'll have an opportunity to opt into the Medicare Advantage plan. First question is, does my doctor participate in Medicare? And nationally, 96% do. And most of doctors who don't participate in Medicare, the majority are psychiatrists. Second is my doctor in network. Most likely she isn't, because the Emblem network is less than majority of New York City physicians. And that might be a problem. I doubt it will be a problem during the first year, but it might be a problem in the out years. Am I concerned about pre-authorizations? And on average, 8% of Medicare claims are denied for pre-authorization. However, those denials are only almost knee-jerk, and about 3/4 of them are reversed on appeal. But it's just barriers. It's just keeping people from using expensive services. If they really need them, the chances are they'll get them. And then, of course, can I afford the senior care premium, which is $22.92 per person per year? If you're in a couple, it's almost $4,500. And really, that's the question that you have to balance. That's my balance. And my final slide, and I appreciate the time, and I'm sorry for taking so much of it, but is this: Medicare is forever. If you opt out and can't afford your senior care, if you opt out and say, I want to be in senior care, but it turns out you can't afford the premium, you will revert to traditional Medicare. You'll have the, the burden of the cost share, but your Medicare is guaranteed. And between January 1st and March 31st of any year, if you have left a Medicare Advantage plan and want to go back into traditional Medicare, in those 3 months, you have an opportunity to buy a Medigap plan, which is a commercial insurance plan that fills the holes that cost sharing doesn't fill, that senior care mostly fills. But if you can't pay for reasons that something happens during the year and you can't pay the senior care, you'll have an opportunity to buy a Medigap policy in the first 3 months of the year, or beginning in October for the following January, you'll be able to opt back into the Medicare Advantage plan. So that's my presentation, and I hope that it helps. And I'll hang around for questions.
Thank you very much, Barbara. And we'll put that PowerPoint on our webpage. In fact, I'll do it this afternoon. I assume it's okay, Barbara, to put that PowerPoint, share that PowerPoint with our members. And so Barbara Katz-Rothman, who I have already introduced, you're on.
Okay. I see there's so many questions popping up in the chat, and I'm actually not going to be addressing any of those. So I'm going to try to keep this really short so we can turn it over to your questions. I'm a sociologist. We see the forest and not so much studying the trees. We look at the larger picture. The larger picture has me saying, I just won't use the phrase healthcare when what I'm talking about is medical services. Healthcare would be air, water, life-giving qualities. We don't do that so much around here. It's certainly, that's very much related to poverty. If you have healthy air to breathe, you're probably in a richer neighborhood. Poorer neighborhoods, fewer trees, worse air. Access to healthy food, all of that. The availability of health care is not universally available in any way in the United States. And what we call public health has increasingly become a kind of an advertising arm for medicine. Here's what you ought to buy, here's what you ought to see, ask your doctor. I've been thinking about this. I've been listening to my colleagues talk about the biomedical industrial complex. And I realized, you know what, guys, we're missing something. We need to look a little bigger. Biomedicine is a colonizing force. It is an empire, an imperial power that has colonized the world. If you think about what an empire is, the economic issues, so for sure. Obviously, just even the pharmaceutical industry is one of the largest industries on the planet. let alone look at how much of, go look at a new shopping mall going up. How many of those spaces are actually being run by various medical related services? If somehow we figured out a way, I don't know, making it up, eating a banana peel a week or something, meant everybody lived until their 80s or 90s and then died in their sleep, the economic crash that we would experience would leave every economic crash we've ever experienced looking like nothing. Okay, that our economy is dependent, our world economy is dependent upon the fact that we get sick and that we take a long time to get better and that we're increasingly defined as sick, whether we're sick or not. Another aspect of an empire is what we call governmentality. It makes the rules. We're hearing a lot about this in the trans world, you know, that you need a doctor to allow you to change sex. Well, you needed a medical person to sign your birth certificate. The person who gave birth to you cannot sign your birth certificate. It needs to be medically assigned. And, you know, the same is true. If you walk in and find an elderly relative you hadn't seen in a week, and you open the door because they're not answering your calls, and you smell rotting meat, and there's a pile of rotting meat on their bed, do not declare them dead and call the family. That's arrestable. Then we need a medical declaration of death. And empires have an element of faith, of believing. And oh, if I had a nickel for every time I heard somebody talk about what they believe or don't believe about everything, chemo, I believe in it, vaccines, I believe in it, I don't believe in it, there's an element of faith. When I talk about biomedicine as an empire, people tend to get very defensive, as if saying it's an empire means it doesn't do good. The Romans built some brilliant roads, I mean, really fabulous stuff. That doesn't mean it wasn't an empire. So I think we need to think about it as an imperial power. This is a little easier in the US because we're paying out of pocket all the time. So we're kind of aware of the cost and profit issues. But the whole world, if there was one chocolate factory on earth that made all the chocolate, in some countries, they would distribute it very fairly. So everybody got a piece of chocolate. In the US, you'd have, you know, billionaires with hoards of chocolate in their attics, and children who are like, oh, I heard of chocolate. Maybe someday I could get a piece. We're not fair in our distribution, but the chocolate factory could care less, right? They're getting the same money for all that chocolate. It's not only the economic control that we see in the biomedical empire, it's also the control of knowledge. And that's something that we're seeing a lot just right now around like the vaccine issue. We're told that vaccines were developed by medicine. In the US, people are being taught that it was Jenner who developed the vaccine. Jenner took something that the milkmaids, people who were milking cows, had learned, which is if you got cowpox, you didn't get smallpox. They infected their loved ones who didn't get smallpox because they got cowpox. Jenner tested it out on his servant's child, worth noting, and then wrote a medical article on it, named it Vaccine, vax being Latin for cow, and it became medically owned. If you make a discovery like that now, don't try it. It's like declaring your grandpa dead. You will be arrested if you do anything that's practicing medicine without a license. So I'm arguing that we're all citizens of a biomedical empire. It's most obvious when we're patients in a medical setting, but it's true all the time. The definition of patient, it's almost funny, you know, bear with me and be patient. If you look at the dictionary definition, as an adjective, it means able to accept or tolerate delays, problems, or suffering without becoming annoyed or anxious. And as a noun, it refers to a person receiving or registered to receive medical treatment. Every conversation with anyone receiving or registered to receive medical treatment talks about delays, problems, suffering, annoyance, anxiety, which is what you guys are all talking about when you're like, which system should I be in to limit those things? When we're in medical services, when we're receiving treatment, and I'm not using the word care, I'm using the word treatment, they're payable treatments, we talk about, like You may know the work of Timothy Snyder talking about hospitals as factories and where widgets going through. It's much more complicated than being a widget in a factory to be a patient. Your body is the battleground. You are not just something going through, but you are the site of the battle. And medicine is very militarized. The actual organization of medicine grew out of the military. Nursing was invented there. The language of orders. You can't order your students to do something. You can assign them, ask them, whatever. We don't have the language of orders in most power hierarchies in the military and in medicine. And so in the medical world, what we saw is that with COVID, a lot of things that were there all along became very apparent to people. The COVID isolation nightmare of people locked up alone and dying, that's the fallback ideal for hospitals. They didn't used to allow parents in to visit their kids because the kids were really difficult to deal with after they'd seen their parents. People are much better at just shutting up and taking it if they're totally isolated, and medicine approves that. If you are the person taking care of a loved one, when you're in that system, you're a visitor and you're not treated as a caregiver. When we're talking about death and dying, which we were so much throughout the COVID issue, every culture has to deal with death. It's a very big deal in every culture. In the biomedical empire, it's a failure. Death is when you can't do anything. And I see some of you really annoyed by what I'm saying and wasting your time. I know you have very specific questions. I will wrap it up. The larger issue is not necessarily useful for you to think about at this moment. I think it is useful for all of us to think about as a society dealing with biomedical management. That the selling of services has been profound. The idea that what you need at the end of life is of services, lots of care. We are not getting that care in any of these systems. The person who takes time off to take care of you is not being helped at all. The doctor, the nurses, all of those services, those are being paid for. If they are prolonging your death and increasing your agony, they're paid even more. We are not providing care. None of these systems are about providing the care that we want. Yes, we have to work with all of this, but we also need to think more broadly, more politically about what it is we want, what we need in the way of care of ourselves as bodies that often are ailing, sick, and sometimes dying. And I will wrap it up there so you can return to the very specific concerns you have at this moment.
Thank you, Barbara. Yes, what we have in front of us is something very specific, making a decision between now and October 31st, but also, as Barbara Katz-Rothman reminded us, something very larger. What kind of, do I dare use the term healthcare, do we want for retirees in this country? Do we want for our sons and daughters and grandchildren and great grandchildren? All of this is of a piece. Today we're going to discuss the specific issues in front of us, but we're going to be continuing this discussion for many, many months. And I would think for many, many years. So we'll open it up to a few questions. Tell us who your question is for, whether it's for Barbara Caress or Barbara Katz-Rothman, who says that we can refer to her as BKR, or for both. Ask a question, be brief. Why don't we do 3 questions and then 3 more? So why don't we start with Jane Herbert, followed by Len Rodberg, followed by Lenore Beakey. So Jane Herbert.
Hi, can you hear me? This is Les Jacobs, Jane's husband. Can you hear me?
We hear you.
Okay. I actually had a question specifically about the plans themselves. Is this not the appropriate time to ask?
Well, plans as Barbara Caress raised them,
Okay.
raise
No, the specifics. Well, let me tell you.
We'll put you first in line for this second part of the meeting.
Okay, that's fine. Thank you.
Yeah, Len Rodberg.
That's what it was.
Len Rodberg, are you unmuted?
Now I am. Okay, I don't want to ask three questions. I want to make 3 points in response to Barbara Caressa's very comprehensive description of Medicare Advantage and the local economics of it. Because I want to point specific, I'll make the 3 points. The first is that, and I don't think she'll disagree with this, that Medicare Advantage is cut rate medicine. Medicare Advantage get the payment from Medicare, which, as she described, covers about 80% of the cost because it was originally designed in 1965, as she said, to on the model then that there would be copays, significant copays and deductibles. So Medicare expects you to pay out of pocket 20% or buy what's called a Medigap plan to cover that 20%. In the case of Medicare Advantage, there's no 20% coverage coming from anybody. They get the payment from Medicare plus some small amount, which turns out these days to be about 4% of the total. So the question is, how do they make money? Because Empire, at least, is a for-profit corporation. And Barbara provided some of the answers to that. The question is even more severe in the case we're faced with because the Alliance, so-called, has said it will pay Medicare rates. It won't cut the payments to providers that Barbara described that other Medicare Advantage plans do. So if they don't cut the rates to providers, how are they going to make money? Well, one way is upcoding, as she said. That's basically fraudulent billing of the federal government, and that's well documented. But it's also by making sure they deny or limit care when it's expensive. Like they'll, you need 30 days of rehab, they'll pay for 3, that sort of thing. So that's my second point, is that they do pay Medicare rates, so they've got to cut costs in other ways in order to break even and make some money. And the third point is, this is something she mentioned, the expectation is this, and this relates to the question of Part B reimbursement. And the current city's position, I was been hoping to see a lawsuit on this, but it's not there yet. Nobody's filed it yet. The city is requiring that you either if you sign up for one of the 2 Alliance plans, or you won't get your Part B reimbursement. So if you choose to opt out of the Medicare Advantage plan and stay in Medicare, but either don't choose to pay for the senior care plan or can't afford it, you won't get your Part B reimbursement either, because you won't be in the city plan. And the city is taking the position that if you're not in what they call a city plan, which is an Alliance plan, you won't get your Part B reimbursement. I happen to think that's illegal, that the city council 20 years ago said that we're all entitled to that.
Yeah,
but the city's position is otherwise. I'm done.
We got to give others a chance. So please, questions, Lenore Beakey? Lenore,
Hi, okay, you can hear me?
Yes.
I have a specific question about our plans. And my question is for Barbara Caress, but I don't know now whether I'm in the right part of it.
Ask the question. Just ask the question.
Okay, I called my first doctor, and the assistant gave me my doctor's NPI. I have not heard anybody mention this in any of these discussions. Maybe I missed it. The NPI is the National Provider Identification for your doctors. All of your doctors have specific NPI numbers. And so then I went to Bill's website, what's happening to retiree healthcare, and to the link to the New York City Office of Labor Relations on retiree healthcare benefits. And I scrolled through this, and at the very end, there is a section called Find Care. And if you put in the county, New York County or whatever it might be, and then the NPI number, your provider will come up or not. So all of my providers actually came up. So my understanding is that the Alliance is claiming that all of these doctors whose names come up are going to be covered by this new Medicare Advantage plan. But something that Barbara Caress said suggests that that might change, and that, you know, so that I can't really count on that. So Barbara, can I count on their NPI numbers coming up or not?
Barbara, go ahead. Barbara Caress. So if Lenore puts in the NPI numbers in 2022 and 2023 and 2024, are they going to appear? Barbara, Barbara Caress, are you unmuted?
She is unmuted, but oh.
Can you hear me now?
Yes.
Okay, I'm sorry. It doesn't, you don't need the MPI number. All you need is the doctor's name. And if they come up as, I'm not sure what you asked. If they're in network and they came up, that means they're all in the network this year and probably will be in the network next year. That's the problem. It's not a stable, 100% stable, but pretty much you can assume that if they're listed as in network this year, they're likely to be in network next year. And that's as far as I can go.
Thank you. If I can, I'll add that Alliance seemed to suggest that anyone who was in the network and then tried not to be in the network wouldn't even be allowed to not be in the network, that they all have to be in the network.
Let me try and explain this really quickly, and I'm very sorry for taking any more of your time. So any doctor who accepts Medicare, which is, I said, 96% of all the doctors in the country, in a Medicare Advantage PPO, there are two groups. There are the in-network ones and the out-of-network ones. But in or out, the out-of-network ones, the insurance companies are obligated to pay them at least what Medicare would have paid. In network, they pay them a negotiated amount, which is typically less than what Medicare would have paid. So when they're saying that any doctor who accepts Medicare we're 99% certain that they'll accept our fee, that's correct. For out-of-network doctors, they're not obligated to do it. They can refuse it. Most will not. 95% of them won't. The only certainty that the Medicare Advantage can promise is that doctors who are in network are most likely, with almost 99% certainty, to be in the network for the duration of the contract year, and that they cannot refuse to serve you. For the out-of-network doctors, the plan promises to pay them what Medicare would have paid them, but it can't obligate them for sure to take care of you. That's the best I can do.
Right, we're going to just one or two more questions in this section. But if people have questions that are relevant to the information session, keep your hands up. Barry Smith and Jermaine Salzberg.
Hi, thank you. I have two questions. The first question is, for those of us in the TIAA retirement program, not TRS, it's still rather unspecific in terms of how we pay this $191 a month per person, because we already have purchased an annuity, which was supposed to cover that. The annuity was obviously not going to cover it. Who do we speak to? TIAA really has no interest in talking to us about this. So how do we find out how we get this paid for?
Yeah, let me take that. I'm not going to answer the question directly now because we're going to answer it in a couple of minutes. But we're going to focus some at this meeting on TIAA, particularly for those who want to opt out. the questions that you raised. So we'll speak to that in a couple minutes, but we will absolutely address that question. And we'll
Thank
also on the website about it. Vivian Miller.
I'm sorry, I had one more question. I had two questions. That was my first. The second question is GHI lists a in their cost list. They have a family plan for GHI senior care. So if we're a family, why can't we intend to opt out. All right, I'm just going to say that right now. This is, to our mind, a privatization of Medicare, which is everything we don't want in this country. We don't. So if we opt out, why can't we get the family plan from GHI? Why do we have to pay $191 each?
We're kind of there's obviously a blurring of lines between the first part of the meeting and the second part of the meeting.
Sorry.
So why don't we in a moment or two get back to that question about family plan and GHI?
Okay, thank you.
That's one of the first things that we'll raise. And let me at this point, because it's almost 2 o'clock. In fact, I think it's almost 2 o'clock. People who have their hands up can keep them up, but let's move into the second part of the meeting. If people continue to have questions for Barbara Caress, well, since Barbara Caress talked about the Medicare Advantage plan, people will have questions for her. Good. If people have questions for BKR, fine, but we're going to bring on an additional team of people right now to answer questions, including the ones about TIAA. Whether we'll answer them satisfactorily or not, you'll be the judge, but these are all important questions that are on people's minds. So joining us in this part of the meeting will be Dean Hubbard, who is the executive director of the PSC and has been talking a lot to people at the Office for Labor Relations, people at CUNY, people at the Alliance. Debbie Bell, the former executive director of the PSC, who, by the way, has a very important piece, as I mentioned earlier, in the new Clarion, which probably most of you haven't gotten yet, and we'll post the online edition on the website, once it's up, an important article on navigating retiree healthcare. And Debbie Bell, before she was executive director at the PSC, dealt with healthcare issues writ large and small at DC 37 for many years. Donna Costa, as you know, is the executive director of the PSC CUNY Welfare Fund. Patrick Smith, whom a lot of you probably have emailed and he's very patiently answered questions, is the communications director at the Welfare Fund. And then one of the members of our retiree executive committee, Bonnie Nelson, in part because she's in TIAA and in large part because she's done lots of research on this, has been helping us address the TIAA question. So what I'm going to ask is, what we'll very quickly do is just a couple of nuts and bolts things. And then we're going to open it up to your questions. So Samantha, if you could put the retiree webpage up on healthcare. And this is, I think, the first place where you can go. So I'm not going to just read from the webpage. I'm going to, maybe in 2 minutes, the first part of that webpage, to get your questions answered. Check the OLR FAQs. Check the Welfare Fund FAQs. Call the toll-free number of the Alliance. And if all that fails to answer your question, and we don't answer your question today, email communications at psccuny.wf.org. And that's Patrick Smith at the Welfare Fund. And if he can't answer your question, he'll refer you to somebody who can. in a moment or two, Patrick and Donna are going to go over the checklist for choosing your 2022 healthcare plan. And as I noted, the article that Debbie Bell wrote in the Clarion is also particularly helpful on this. The third item there, chapter meetings and information sessions. The PSC has had 2 information sessions with the Alliance. That's the group that's doing the Medicare Advantage plan. We've had several chapter meetings. There are videos of all of this. We will also put Barbara Caress's PowerPoint on. So that's all available. Next thing, enrollment guides. Hopefully everybody has gotten an enrollment guide. If you haven't, I'll speak to that in a moment or two. So there are 2 enrollment guides. If you're on GHI senior care, as I am, and probably as 90% of us are, that's one enrollment guide that you've gotten for you to either enroll in the Medicare Advantage program. Well, actually, you don't have to enroll. That's the default. But within that guide, I think on pages 34, 35, 36, there are opt-out forms if you want to opt out on and remain on senior care. And more recently, they've sent out enrollment guides for the Medicare Advantage to those of you who are on HIP, VIP, Aetna, other plans other than the GHI senior care. And there are also opt-out forms there. More importantly, if you scroll down, as Samantha has done, there are opt-out forms, links to opt-out forms right there on the website, if that's what you choose to do. There's also a link if you want to opt out of the city plan altogether. But if you do that, at least as it stands now, given the city's interpretation of the law, you will not get Medicare Part B reimbursement, or if you're eligible, IRMA. The charts for these plans, there's a link there, on the OLR, the Office of Labor Relations site. As you look at these plans, remember the one thing that you are not paying as you're looking at the rates in these plans is for pharmaceutical or drug benefits. You are covered by the welfare fund, whether you go into Medicare Advantage or stay on senior care or stay in any other plan offered under the umbrella of the Office of Labor Relations. You should have gotten a July mailing from the PSC. The link is there. Your correct mailing address. If you have not gotten anything from the city yet, you want to make sure that the city has your correct mailing address. You also want to make sure that the PSC, if you haven't been getting mailings, and the welfare fund have your correct mailing address. The information is there. And then if you scroll down just a little more, Samantha, the 365-day hospital rider. For those of you who are opting out and you want to continue to have that 365-day hospital rider, if you have it, from what I understand, you're grandfathered in. You will continue to have it, and you will not only be billed for the $191 plus a month, but the $2.83 a month for the 365-day rider. And there's a number there you can call if you want to find out if you have the rider. And I'm told, although we haven't been given a link yet, that the Office of Labor Relations is going to create a form. If you don't have the 365-day rider and you want to sign up for it, you'll be able to. But as of this point, we don't have that form. And then finally, a reference to that article by Debbie Bell, Navigating Retiree Health Insurance, which is soon as the Clarion is posted on the PSC website, which will be today or tomorrow, I believe, we'll provide the link to that. What I'd like to do now, if you can take that down, Samantha, is go to Patrick Smith and Donna to talk about we went over this last time, but I think it's really important what you've got to do in terms of choosing, your healthcare plan. Then we'll go briefly to Dean Hubbard to talk about existing lawsuits, and whether they'll have any impact on all of this. And then we'll go again back to Dean and to Bonnie Nelson to talk about an issue that lots of you are concerned about, at least those who are opting out. And in TIAA, which is the majority of our members, is what will be arranged by the city and with TIAA. So Patrick and Donna, you want to walk us through very quickly choosing the healthcare plan, which one iteration of it is on that website that I just showed you. It's also on the PSE CUNY Welfare Fund website, and Patrick, hard copies were sent, not just sent to PSE members, but everybody who's getting welfare fund benefits recently. So Patrick and Donna.
You want me to share it, Donna? Share the screen? Okay. Bear with me. No. All right. Sorry. A little bit of a glitch here. All right, you got it?
Nope, I don't see it.
You don't see
Is
it?
that up?
Okay. I've got it up on my end. Let me go back to Zoom and see what happens. Okay, now if I share screen. Damn.
So Samantha,
All right, I'm going to try and get there. I'm going to see if we can get there another way. Or maybe,
Samantha, is Patrick a co-host so that he can share his screen?
Yep.
I'm sure it's on, but Samantha, if you go to our website, you go to the Welfare Fund website
Uh-huh.
and click on just go to our homepage
Mm-hmm.
and click on the big red letters that say Medicare Advantage FAQs.
Yep.
And then on that page, you'll see an entry that says the opt-out checklist. You just got to scroll down a little bit. I'm going to go there myself and guide you to it. So you got to our homepage?
Yeah, let me just share my screen. Hold on, just to make sure I'm in the right place.
Oh. There it is.
Is this correct?
Let me get back to Zoom.
You have to double click on the checklist. Right here.
Here you go. Okay, that's it.
Okay, the first important thing you have to do is, if you are choosing to stay in the Medicare Advantage program, you don't have to do anything. So that's the number one thing to decide what you're going to do. If you are going to stay in the program you are in now, which may be the GHI senior care, then you should have gotten the opt-out enrollment form for GHI senior care. Then you would use that opt-out form for that program and fill out the information for, if it's just for yourself, you would fill out all the information for just yourself, and you would have to either mail that or use that, or you can go actually to the website and put the information into the website. It has to be done for everyone who is on the program, if that's for yourself, or any dependent that may be on that program. So if it's you and your spouse, it has to be for you and your spouse. Anyone who is a dependent has to follow the person in the plan. If you are in a different program, you should have gotten a different opt-out letter. So if you're in the Aetna program and you're staying in the Aetna plan, then you would have to go into the Aetna. You wouldn't have to, but if you wanted to stay in the Aetna plan, then you would use that Aetna opt-out letter. That's correct, isn't that, Pat? Have I left anything out of that part?
So far, so good.
So that's that as far as the opt-out. If you are in, as Bill had said before, if you already have your 365 hospital rider, you will already get, when you opt into your GHI senior care, that will also automatically put you into the program. If you are unsure whether you have the rider or not, then you will call the number to make sure that you have the rider. If you don't have the rider and you wish to get the rider, then you have to wait for the transfer period, which this year is from November 1st to November 30th. You can then decide to get that rider. That will be effective for January 1st, 2022. And you can opt to get that in January along with your GHI for January 1st, 2022. The second thing you can do is you can choose to waive, which is not the same as opting out. That means you are waiving your coverage completely. That's similar to what you might have done when you were full-time active and if you had a spousal coverage and you decided you did not want to have any city coverage. If you were to do something like that, that would mean that you might not get reimbursement for your Medicare B or your IRMA. They are still, the PSC, the union is still challenging that, but at this point in time, they're not sure. So be very careful if you decide to waive New York City coverage completely. That may leave you without reimbursement for Medicare B and IRMA, and it may leave you without any coverage for your additional coverage or supplemental coverage, and it may in fact leave you without welfare fund coverage, and it may leave you without any kind of Medicare Part D prescription drug coverage. But that is another option, and you should in fact be very careful about doing something like that. Pat, did I leave anything out of the opt-out forms?
No, I think you got it. But let's just reiterate that no matter what you do, except for waiving your benefits, if you waive, you will, at least the way it's construed now, you will lose drug coverage from the welfare fund. You will lose your Medicare Part B reimbursements. And if you are charged IRMA, you will lose the ability to apply for reimbursement of that IRMA. But if you opt out of the Medicare Alliance plan and keep your current plan, your drug coverage stays the same. If you say, I'm going to take the Advantage plan, you do nothing, your drug coverage stays the same. You will still be enrolled in the PSC CUNY Welfare Fund SilverScript Medicare Part D prescription plan. That is unaffected by any choice you make except waiving your city benefits entirely.
You do not need and you should not purchase the drug rider. In fact, if you do that, it will kick you out of the welfare fund's plan. And the welfare fund plan is a much richer plan than the rider. So please be very careful not to get confused. And one other point we want to make is that in this section, in this piece of this end part of the year, you're going to be getting a deluge. And Pat, I'm sure you can't say this enough, of mailings from Medicare Advantage plans, from Medicare Part D plans. They're going to be telling you that you should be looking at all your plans. Give us a call. Let us check your plans for you. You should be signing up. Be very, very careful. If you do not see things that say PSC CUNY welfare funds or New York City plans, do not sign up for anything, because it will disrupt the plans that you have in place now, whether it be the GHI senior care plan, the New York City Medicare Advantage plan. This is what happens every year at this point in time, and it will only get any insurance that you have disrupted. We get calls every year about our members losing their insurance. It's always Medicare Part D, and we anticipate it'll just be even worse this year because of what is going on. So please be very cautious in any of these mailings. Be very, very careful, and only pay attention to the ones that say PSC CUNY welfare or anything that says New York City retirees. Pat, I don't know if you have anything to add to that, but this is a very, very, very confusing time of year.
Just to go back to the opt-out form, I've heard from a number of members who said they haven't received a single piece of paper from the City of New York or the PSC for whatever reason. That doesn't mean it didn't get sent to them. I mean, a lot of people, we get so much junk mail that you just automatically throw it all away. However, if you have not received anything from the city about opting out, and you don't, everybody here obviously has a computer. If you have friends who you know or have mentioned to you, wow, I haven't heard anything, I haven't gotten anything in the mail, I don't know what to do, you can opt out over the phone. You can call that Alliance hotline number and opt out over the phone. If you're afraid of paper, and by the way, the email and electronic submission of that opt-out form is encrypted and secure. You don't have to worry about that. But if for whatever reason you didn't get a piece of paper, you can't go to the website and pick up the form there from the OLR, you can opt out over the phone. It's just as efficient, and you can get it done, and then you're not waiting for something in the mail. And that number, which you have all had banged into your heads 300 times, I will repeat again, is 833-325-1190. You can call that number and opt out over the phone.
By the way, I understand that if you opt out using email, you will get a confirmation by email. I'm told that everybody who opts out should get a written confirmation by the end of November. But I know that that's a concern of a lot of people who are opting out. How can I make sure that, I'm still on traditional Medicare and on the New York City senior care plan? So more on choosing your healthcare plan, Patrick, or?
Well, I think we've covered the details of the opt-out process. And that was, just for practical purposes, that's what we wanted to focus on. Donna and I can take questions related to.
Why don't we first go to, hopefully Dean is on this Zoom call. Originally he said, and Dean can fill us in on, what's happening in terms of lawsuits, and particularly the question of whether the legality of OLR's interpretation that you will only get Medicare Part B reimbursement, and if you qualify, IRMA reimbursement from the city if you are either in the Medicare Advantage plan or opt out and stay on the plan that you're presently on. Is Dean there?
He is not here yet.
Dean is not here yet.
No.
Okay. When he gets, let me just say that a lot of you, I think, probably know, because it's in the press, there are a number of different lawsuits working their ways through the courts. One filed by Aetna, a finalist, with the city and the MLC when they were choosing, which Medicare Advantage plan, would apply. They've sued. Evidently, United Healthcare has sued. I don't know what that's necessarily about. And an organization of retirees has done fundraising to raise $50,000. I think they've raised 2/3 of it to hire a lawyer, arguing that what the city did and MLC did was illegal, and that they're trying to get an injunction in the courts. Evidently, that case has been linked with the Aetna case. I don't want to go into the details of any of this. I'm not a lawyer. But I think we've got to operate on the assumption until we're informed otherwise, that it's status quo ante, that, what we've got to prepare for is the decision that has to be made between now and October 31st. If that changes, obviously, we're going to inform everybody. And so I know nothing about, whether any of these lawsuits are going to be successful or not. Dean is, well, let me just say that the PSC has talked to outside counsel to investigate whether we should file suit around this issue that Len Rodberg raised earlier in the meeting, and that is the legality of the city claiming that if we don't stay in one of the city plans, we will not get reimbursed by the city for Medicare Part B or for IRMA if we qualify. We're still meeting with outside counsel. As of this point, they just don't think we have enough to be successful in the courts. So that's where that stands. And when Dean comes on, he can tell us more. Bonnie,
Hey, sorry, I was.
Oh, you
muted
are
by the
here.
host,
Okay.
but- Yeah,
So Dean, you just heard what I said. If it's wrong, you'll immediately correct me. But what we were just asking is, what's the status of current lawsuits, and what's the status of our inquiries, with outside counsel about the legality of the cities arguing that nobody is eligible for Medicare Part B reimbursement or IRMA unless they're on what the city considers a city plan.
yeah, I did hear your analysis, Bill, and it was right on point and consistent with what I'm hearing from our lawyers. As folks know, Aetna has sued the city and the MLC over the RFP process that led to the so-called alliance being granted the contract to handle the administration of the Medicare Advantage Plus program. That is, going to wind its way through the courts. Unfortunately, I think from our perspective, of course, Aetna has no interest in challenging the fundamental decision to privatize the administration of tradition, even if they prevail in the lawsuit. The best case is that there's a new RFP process. So I don't think that is one that necessarily dovetails with the interests of our retirees. There also is a case that I know that folks are aware of that's been brought by an attorney whose name I believe is Steve Cohen, that does challenge the basic decision to to move away from traditional Medicare to the Medicare Advantage Plus program. Our outside counsel is actually in conversation with him and is trying to get more information to convey to us about, how solid he thinks that those causes of action are. But so that case is also out there. Then in terms of the questions we've been looking at, yes, so Len Rodberg and others had raised the question of whether the city was correctly interpreting the local law that the city believes means that if you're not enrolled in a city health insurance program, you're not eligible to be reimbursed for your Medicare Part B or your IRMA. We have had outside counsel take a look at that. I don't want to get too deep into the weeds, but I think the bottom line is they think that while we have a good argument with respect to the intention of the city council, the language of the actual local law gives us a bit of a problem because the city is interpreting it consistent with the definition of a health insurance program under the law. And so it's difficult to persuade a judge to look at legislative intent unless the language is a lot more ambiguous. But we are in the process of arranging a meeting between outside counsel and some of our retirees who've been particularly active in looking at the legal issues. And hopefully that will give folks a deeper insight into where we are on these questions. Go ahead.
No,
Bill.
go ahead. I'll interrupt you. Go ahead. These screens seem to have frozen. I just wanted Dean and Bonnie Nelson to talk about TIAA and what we know in terms of how members will be billed if their annuities with TIAA don't cover the
The
cost.
only other thing I believe, look at the question of senior care plan. Can you hear me?
Yeah.
Bill? Okay. So we have met now a couple times with both OLR and CUNY to try to clarify these questions about how people who are on TIAA are going to pay their premiums if they make the decision to opt out and to stay in senior care. The first thing I think that folks need to be aware of is that now would be the time, if you're planning to opt out, that you check in with TIAA to make sure that the annuity that you have from them is big enough to pay the premium if you decide to opt out. And if it's not, you should either increase the size of the annuity or be prepared to be direct billed and be looking for that bill early in the new year. OLR has agreed with us, and they have talked to the so-called alliance about direct billing folks whose annuities are not large enough. The way that it will work, we don't know yet whether they'll be able to automatically debit your account if you want that. They're checking into that for us. But basically the timeline is that obviously, January 2022, when this whole thing goes into effect, would be the first time that the new higher premiums would be deducted for people who opt out. And if your annuity is not big enough to pay the premium, nothing will happen at that time. If your annuity is not sufficient to pay the premium, then OLR will notify Emblem, and they will send a letter to everyone who's missed those first two payments, telling them that their annuity is not sufficient how they should contact TIAA to increase it, and that they will be direct billed. And the letter will also notify people that if they don't pay their premiums, they will then be, and the OLR is also committed to us to try to include in this letter how much the individual owes and how they can pay Emblem. So that's February. Then if the retiree actually then goes on and misses payments, 4 payments, that would be January, February, March, April, then at that point, OLR will move the person. So basically what we worked out with them is if you're in TIAA and you opt out, but your annuity is not big enough to pay your premium, but if you miss 4 payments, they're gonna put you into the Medicare Advantage. They will work with you after that to move you back if that's what you want to do. But folks need to be aware of that, and be aware that, you know, now would be the time to reach out to TIAA to find out from them if the annuity that you currently have is large enough to pay your premium if you decide to opt. I don't know if folks were able to hear me. I apologize if I was breaking up. And if I left anything out, or if there's anything to add, Bonnie can certainly follow up.
Bonnie, you have anything to add?
Maybe I can just try and summarize it and repeat because Dean was breaking up a lot. So basically, people on TIAA, the city and Emblem will expect that your premium is going to be paid out of your annuity. If all you annuitized was the required $10,000, then your annuity, your monthly payments are almost certainly not enough to pay this higher premium. If you wish to continue paying out of your annuity, which is probably the easiest way to do it, you should check with TIAA to find out if your monthly annuity payments are sufficient to pay the premium. And if they're not, then you can talk to them about increasing your annuity by annuitizing more of your money with TIAA. If this is the way you want to pay it, you should do this as soon as possible so that it's in place before January 1st, because then you would want that January 1st annuity payment to be sufficient to pay your premium. If your annuity on January 1st is not sufficient to pay the premium because you have opted out, then nothing will happen. This is the way the city automated system is set up. They just consider it a missed payment. On February 1st, if again your annuity is not sufficient, then they will notify Emblem. And at this point, it's a little confusing to me. I don't know if Emblem will at that point get in touch with you, or if the city will get in touch with you at that point. But at that point, they say, okay, you don't have enough, and Emblem will direct bill. But I don't know when you're notified. I don't know when you get the bill. It's possible you might not get the bill until March, but the city is supposed to notify you after you've missed that February payment. We don't know yet whether Emblem is able to do direct debit from your checking account. We kind of assume they do, but we haven't had confirmation of that yet. So this is what we know. If you want to be direct billed, it will probably be a little bit messy at the beginning, but it should work. And you're not going to lose your health insurance because you've missed the January and February payment. That's just the way the system is set up. I hope that was clear.
Okay. So there's a lot to unpack there. I think we need to go to questions. And why don't we start with, I believe it was the husband of Jane Herbert, who I said would be back. Yeah, I see your number 3 online. I promised, since you raised a question earlier that you thought didn't belong in that section, I promised that you would be the first in this section. So Jane Herbert or Jane Herbert's husband.
It's Les Jacobs. I'm also a CUNY
A member of the family.
Yeah, yeah. Anyway, I'd love to join the union, but I'm not a member of NYSUT. So anyway, well, that's a different story. Actually, I just heard something, so I have a quick question. Do I need to use the Aetna letter? And I cannot do it online since I'm on Aetna?
To use the Aetna letter?
Well, I got the Aetna, the opt-out letter from Aetna. But I was just told that I cannot do this online if I'm on Aetna. Is that true, or can I still use the online form? I can't hear you.
I don't know. I've never heard of that. I think you can use that letter absolutely fine. You just don't want, the one you don't want to use is the GHI one. That's all. There's two letters, one for folks on GHI and one for everybody else.
Right. So, but can I do it online as opposed
Yeah.
to using the letter? Yes. Okay. Thank you.
Are you going to stay in Aetna or are you going to?
Absolutely.
Okay. Then you
Okay,
don't,
yeah.
if you're, okay.
All right. And my wife as well. I'm asking the questions for her as well. I'm trying to get a question, and actually was alluded to earlier by one of the good presentations. Right now, we pay through TIAA $89 a month for Aetna. And now when I look at the rate charge, it says it's zero. No one from Aetna is able to answer the discrepancy on why they would give us, quote unquote, more services for less money. And I've also seen nothing that compares the current Aetna plan, which is a Medicare Advantage plan, and it's excellent, by the way, to whatever plan is being offered next year. Does anyone there have any intelligence on Aetna? We kind of feel like orphans because we're TIA and Aetna, which probably makes us 3% of your population.
They're trying to compete with the Alliance. And it might, very possible it might have something to do with the lawsuit.
Okay,
So they're offering the same coverage as the Medicare Advantage plan that's currently being offered at $0. So you're getting the benefit of what's now being offered.
I'm sorry, that's what they told me, but of course I had trouble believing them, even though they've been excellent.
That's what it is. Now,
So you're paying zero. You're instead of paying $89, you're paying zero for it, and you're getting the additional benefits that they're offering the Medicare Advantage members.
And just one other point of information for a lot of other people, I think, who are on the call. We had occasion, unfortunately, this year of needing to consult with a physician from Sloan. And Sloan is not on either program, either the Medicare Advantage program that's being offered by the city, nor on Aetna. But when they did, and they gave us a pretty hard time, but when they checked the Aetna program, they took it. We had no problem. We paid our $15 and that was that. And so things may be the same with the Medicare Advantage program, even though MSK, I don't believe will ever sign up with these programs. Just a point of information. Thank you.
Thank you.
Yeah, thanks. Vivian Miller?
Thank you. When Barbara Caress, and I hope I'm pronouncing her name correctly, was speaking, she said that they're still negotiating or they didn't finalize things. I was under the impression what we got in the mail was finalized.
Absolutely. Yes. Yeah. The answer is yes and yes. So the plan details are final. The plan details are finalized, but the contract is not. That's not unusual. I ran a big health fund. We changed plans periodically. We'd operate under an MOU until the contract was finalized. The kind of details that I was asking about in my PowerPoint are things that will be dealt with in the contract and don't have a direct bearing on what's going to happen next year.
Okay, so I can have faith in the booklet is what you're saying.
Correct.
Okay, second question, if I choose to opt out, how would I be billed?
That depends whether you're in TIAA or.
Oh, TRS.
If you're in TRS, it's simply going to be taken out of your monthly payment by TRS. I mean, that's how the city operates. So people who are in TRS and opt out, you don't have to worry about payment. It will be, as I said, deducted from your monthly check from TRS. And there should
Thank
be
you
enough
all.
money there to cover that. Yeah. Linda Sharif? You unmuted, Linda? We don't hear you.
Okay, here we go. You hear me now?
Sure.
Great. I have a couple of questions. One will be, will there be an IRMA in the Advantage plan? Yes, there will be?
I assume, yeah. Why not?
Well, I would hope there wouldn't be, but it would be on the same scale.
IRMA is related to your modified adjusted gross income. It doesn't have
Right.
anything to do with what your
Right.
Medicare supplemental is.
So, but so it will still be coming out of my pension, yes?
Social Security.
Yeah.
It's,
Yeah. Okay. The other thing, the more important thing is we left New York 2 years ago. We're in Connecticut. In any way, will it be different for us if we stay in the plan, in terms of, what networks we'll be in and what our benefits and what our benefits remain?
Are you planning on, are you talking about Medicare Advantage, or are you still talking about going to GHI senior care?
Medicare Advantage. I think we're going to try the Medicare Advantage because we can opt out next year if we're not happy with it.
It should be, they're saying that it's a provider network, and any doctor that is in Medicare accepts Medicare is a provider. So if you go to a doctor that accepts Medicare, then any doctor who accepts Medicare, you should be able to see. They would have to be, the best thing you can do would be to check with the doctor beforehand or check with the Alliance to make sure that they are aware of the plan, because this is a new plan. So you would definitely want to check with the doctor that you're going to beforehand to make sure that they're familiar with the plan. And I would definitely call the 833 number to see if the doctor knows about the plan ahead of time, because I'm expecting that there will be a lot of, there's going to be a lot of getting up to speed on familiarity with the billings. But any doctor that it's a PPO plan, and any doctor that accepts Medicare should be able to accept the plan.
And my domestic partner, she'll automatically be enrolled as well into the Medicare Advantage plan?
As long as she's a dependent on your plan now, yes.
Yes. Okay.
Okay. So Maxine Wolf? And unmute yourself, Maxine.
I have two things quickly. One I put on the chat, which is if we do do the opt-out form electronically, if we send it in electronically through their site, are we going to get an acknowledgement of that?
I think immediately you get a signal that says success. It tells you that the form was officially uploaded. So if in the process, they send you a message when they've gotten it correctly and it says success.
Well, I hope that means that it will be successful. My other question is, it's not a question, it's a suggestion. I don't know how many people are opting out and how many people are not opting out. I'm choosing to opt out. But I would like the chapter or the union to actually do a survey somewhere around July that would ask people, that would let us know how many people have opted out, and also ask people what their experience has been.
From name unavailable.
Yeah, that's.
From name unavailable.
Does somebody, if you can mute yourself.
Somebody is in.
Unavailable.
You want me to mute myself?
Um,
No,
I-
there you go.
We're hearing a competing sound there. Yeah, I'm a little reluctant to do that because I don't think it's any of the chapter's business, you know, whether you're going into the Medicare Advantage plan or opting out, unless we could do the poll anonymously. But we'll look into that.
Well, the city must have, you know, records of whether we're out. I'm not asking for individual information, but I don't see why we
If
couldn't.
you're willing to give us that information after October 31st, we'll certainly provide it.
Okay, and I do think that having if you're not going to do a survey of people's experiences, maybe we could do an in-person meeting. It should only happen, or a Zoom where we could actually share our experiences with one another, because I would like to know people's experience. If I have that possibility of opting in again next year, why would I do it without having information from people?
Absolutely, we should do that. Absolutely, we'll do that. Absolutely. We will create some kind of format where people can share experiences. That's really important. So that's something that we'll definitely follow up on.
Okay.
So this doesn't end on October 1st or December 31st. We want to know throughout the year in 2022 exactly what's happening and whether people are satisfied, not satisfied, what kinds of questions they have. So yes, we absolutely have to accumulate that information. And
I will also, I just want to share with people that I called up the radiologist that I have used for 25 years for mammograms, who then told me, and who's always taken Medicare, that he will not take any Advantage plan. He didn't care whether it was this one or any other, and that I would have to pay up front, and then they would send in papers and I could get the money back. So the idea that just because he accepts Medicare, he would accept this is absolutely not true. So I wouldn't trust the list. I think people have to call their own doctors to find out directly.
Yes, people need to call their doctors. I'm going to move on because
Go ahead. Sorry.
We got a lot of hands, and so Andrea Savage, you're muted, Andrea.
Mute. There we go. Two questions. First, could somebody tell me the provider network that will be used to cover New Jersey? I think the speaker said there was a different one for New York. No, so what's
your second question?
Network is it then? Could you tell me?
Medicare.
I don't mean, but no, there was a comment about in-network providers.
No, it's any
Caress.
doctor who accepts Medicare.
No, I don't think that's what the question.
Barbara Caress
is. Barbara Caress. I mean,
she mentioned two different provider networks.
They do have
one for
provider
New York and one.
No, they do have provider networks, but it's a PPO, so it's any doctor who accepts Medicare. You don't have to go to an in-network provider. Any doctor who
there's a
accepts
question about an in-network provider.
you are allowed.
No, I do understand that. I was responding specifically to the speaker who mentioned two different networks, one for New York and one for New Jersey as the basis. I'll leave it at that. It's fine. The other question I have is that when we're in a reimbursement situation, when we're in a reimbursement situation, that is, our provider says we should pay them up front and then we will get reimbursed. Will we get we're not going to be reimbursed for the whole amount of their bill, right? We'll be only reimbursed up to the Medicare payment, the Medicare charge.
If you see a Medicare doctor, they will. They're not. I believe they're allowed to charge 115% and you would be reimbursed 115%.
Thanks.
So Dan Mosenkis, I hope I didn't butcher your name.
No, you
Dan,
got it fine.
muted?
Yeah. Okay, so one was just answered. The other question is, we have a catastrophe policy. Presumably that covers situations where you get $100,000 in bills for stuff that wasn't covered. Will the Medicare Advantage plan, is that included when they say maximum annual out-of-pocket expenses?
Are you talking about the legacy? The legacy, what did we call it? Rollers, Patrick? Are we talking about that?
If we're talking about the welfare fund catastrophe major medical policy that early on had the name Wohlers, then it was administered by Marsh. Now it's administered by Mercer Consumer, and it's confusing because the NICET catastrophe plan also is administered by Mercer. But those plans are completely separate from the rest of this. If you have significant out-of-pocket costs, then you submit for reimbursement. You pay those bills and then you submit to the plan for reimbursement. But they do not coordinate with the Medicare Advantage plan or with GHI Senior Care. This is a reimbursement policy, and you've got to get EOBs from Medicare showing what they paid, EOBs from, say, Senior Care showing what they paid, but you are submitting to that insurer, in the case of our the welfare fund policy, which we call the legacy policy, to distinguish it from the NICET question. Go ahead.
The question was more where this new Medicare Advantage plan says there's a maximum annual out-of-pocket.
There's a maximum annual out-of-pocket of, I think it was $1,600. Do I have that?
Does that mean I don't need catastrophe insurance?
The Wallace catastrophe is a slightly different plan because it will cover over 10,000. I'm sorry, it covers you over a 10-year period. There's also things in that plan that's not covered by the Medicare Advantage plan. There's some type of home health aid coverage in it.
It will reimburse for 300 home health care visits per year.
And there's a nursing.
Reimburse $400 a week for long-term care assistance. It will reimburse for a certain number of private duty nursing. I think it's something like $30,000 worth of private duty nursing, but it's all reimbursement. Those are the things that our members are finding most useful about the catastrophe plan. Not so much the reimbursement of very high out-of-pocket medical and hospital costs, but more for things that Medicare does not cover, such as home health care aids, a little bit of coverage for long-term care. It's no substitute for a long-term care policy. There's just a little bit of coverage, and reimbursement for private duty nursing at home or in the hospital.
Thank you.
Yeah, so you probably want to take a look at it and see the cost of it. I think the annual cost of it is not really an expensive plan, but it's something you might want to look at and see if it's still worthwhile having.
Yeah. Stanley Habib, make sure you're unmuted.
Okay, thank you. Welfare fund has been great. Donna, the question is sort of for you, and it could relate to opting out, which I'm not going to do. But here's my question. In my Silver Script statements, there's a portion that seems to be covered by Medicare D. Is that all right? So where's that money coming from? And the reason I ask is typically Medicare D is covered by some Medicare Advantage program. Not in this case, you're saying.
No.
Is if I was concerned that eventually the Medicare D portion of the Silver Script coverage was suddenly, we were told you have to pay, which Patrick said he did not think would happen. But you understand my question?
We do, the Silver Scripts is a Medicare D program. It's been a Medicare D program for, I think, I'm trying to remember how long we've had it in, since 20, I think it's since 2014 now, I believe.
That's right.
We've had it in place since 2014. And it's been such a huge, and I don't want to take up too much of this time because it's really not part of what this program is, but I'd be happy to have the conversation with you off to the side. But it's been one of the reasons why we've been able to keep the retiree program as rich as it is, because otherwise you would have been, as you know, we don't have any of the caps and the tiered copays that we have as retirees, because we've been able to get the subsidies that have been able to keep us in with the retirees prescription drug programs.
Right,
So
right.
we do have Medicare Part D program, and we've been able to get those subsidies from the government, which help us to keep it as rich as it is. I think that's the best thing. But if you'd like to, like I said, I can have a fuller conversation with you. This isn't really the place to have it because it's more detailed.
Yeah, no, I thank you. The reason I asked the question is if I was concerned that eventually Medicare Advantage would insist on my paying Medicare D, that could be a consideration, but it's not at the moment. Thank you very much.
No, you're very welcome.
Jackie DeSalvo? And Jackie, make sure you're unmuted.
All right, I'm off mute. My husband's going to ask my question.
Hey, hi Bill, how you doing? Doug. All right, so Jackie and I, Jackie has Medicare with I'm going to ask this detail because I want to make sure I'm doing this right. Has Medicare, and then she has an Emblem Health GHI Senior Care Medical Plan. We want to keep, and I have this, I'm on that plan as well.
What do you mean?
Jackie, let me use, it's as a tertiary. We want to keep exactly what we have. So I went to, if I understood correctly, I went online and I downloaded this form, opt-out form for New York City Medicare Advantage Plus plan to opt out of it. And if I understand it correctly, the first section asks, says it should be completed by the Medicare eligible participant. So in one case, that would be me. And in another case, in the second case, that would be Jackie, because we both have to fill this out. Then underneath, it says, complete this section with the city retirees information. In both cases, that would be Jackie. Is that correct?
Yes.
Okay. And then this rider plan, if we want to keep exactly what we have now, we do want to pay the additional $2.83. Is that correct?
Yes, you'll be grandfathered in if you actually have it right now.
Okay, so I'm assuming she has it. I don't know what it applies to.
Well, at the beginning of the meeting, go to the retiree healthcare webpage, and on there, there's a number that you can call to find out if you actually have it.
Okay, all right. And then after we've sent in this form, this question was asked before, and Patrick answered saying we get a note that says success, but it doesn't provide us any evidence that we've actually done it. We have nothing in our hand that says, is there, that we've actually filled out and successfully completed the opt-out form. Can we call this number, the 833-325-1190 number, and get something sent to us or emailed to us, or so that we know we've done this correctly? Because I've had some horrible situations with medical bills where the things we did right, but the other end did them wrong. So
the city says everyone who opts out will be notified, and it will be confirmed by the end of November.
By the end of November. Okay.
Right. As I noted before, if you do it by email, if you scan in the opt-out forms and send them in by email, you should get an email confirmation. And also you can, if you haven't done it already, you and Jackie should go to medicare.gov or Google My Medicare. Make sure that you have a My Medicare page. And that should tell you exactly what coverage you have. So in December, if you check that, it should say you are still on New York City senior care. It'll also indicate that your drug coverage is through Silver Scripts. So, I mean, that's the fail-safe. But the question you raised, Doug, excuse me, is a question that lots of people are raising. You know, how do I get confirmation? So, important question, and I hope we answered it. Although, you know, I wish we could get a more solid answer from the city in terms of confirmation. But we will certainly follow up on this.
I don't know if this has been covered, but the question that's been perplexing me, I don't know if Doug understands it, is that right now he has me as his tertiary, and that gives him all the welfare fund benefits like hearing aid, blah, blah, blah. But it also requires paying for him and me for the 191. Is that?
Jack, I'm going to interrupt. I'm going to suggest that you contact Patrick. You know,
Okay.
about the specific question, you know, regarding Doug's tertiary coverage, and that we move on because a lot of other people have hands up. So important question for you, but, you know, contact Patrick. Jane Mushavek. And hello, Jane. Are you unmuted?
Yes, I am. Thank you. So I wanted to pursue this question about the prescription drug premiums. Could I call Donna? Could I call you and ask you specifically about my specific situation?
Yes, please do.
What is your number?
Call the 212-354-5230. You'll ask for Patrick Smith, but he's going to give you over to Jen Melfi.
Oh, but that's not to reach you?
No, you'll get Jen Melfi, who handles prescription drugs.
Jen
Melfi, M-E-L-F-I.
Okay, thank you.
You're welcome.
So Abraham Held. Are you unmuted?
Did I unmute?
Yes, you did. We hear you loud and clear.
It keeps telling me that I cannot unmute, so I'm muted.
You're unmuted.
I want to say that I am sending in the forms that I found online. I'm not waiting for the union makes a wonderful job of giving information online, the best. I'm not so happy about these Zoom talks, but I am sending in the forms. I'm filling them sensibly. I'm sending them in by fax, because at least I have a piece of paper that I sent in a fax. I am receiving well over $10,000 a year from TIAA, and I am therefore not worried that the $6,000 maybe that this will cost me to will be paid out. So I think I can rest assured. And I think that everybody else in the same situation should do the same. Thank you very much.
All right. Thank you, Abraham. And check with TIAA. It's probably the best thing to do. Michael Bloomberg.
TIAA does not, I will call again tomorrow, but generally they just don't know what I'm talking about.
Well, okay, but if you continue to have questions.
Right now, I am already paying for my.
Abraham, you know, I think we should go on to the next question. If you continue to have issues with this, email us and we'll certainly deal with it.
Hello?
Michael Bloomberg?
Yes, here, thank you. This is for Patrick. I emailed him on Friday. I've also spoken with him earlier. Been exceptionally helpful. I want to acknowledge that. I'm at the point where both my wife and I will probably opt out of the new Advantage plan and file the appropriate papers, each of us filing our own. We will also choose, I believe the expression is, to waive my New York City coverage. I understand the problems associated with that, such as non-reimbursement of my Medicare premium and also loss of the health plan. But my question is, and this is because I have another form of coverage that is probably going to be available to me, that will suffice. So I want to fill out this application change form, and I have certain questions about the form itself, and I did address them in an email Friday, like I said, not directly to Patrick, but to communications at PSC Community Welfare. So if you want to go on to someone else, I understand that. But essentially, I know I check retiree box. I know on Section A, I check waive benefits and put the effective date of January 1st, 2022. I don't believe I check anything in box B regarding my spouse. Part C, I don't do. Part D, I have to put my information in. Part E is about spousal information. My spouse is not.
Michael, I'm going to suggest, since there are lots, it's an
I'll talk
important
to Patrick.
question for you, obviously, very important question. So I'm not trivializing it, but as you say, Patrick is very giving of his time, and will.
Understood. We can go to the next person. Thank you very, very much. Appreciate it.
I'll call you, Michael. I will call you.
Okay, very good. Thank you so much, Patrick, and thank you all.
You bet.
So, Sandra Lefthoff, you're on.
Okay, good, thank you. I have a question about this being informed. And I know obviously a lot of people are concerned that they're going to opt out and then have to wait till November 30th to find out. That's really very anxiety provoking. So the question I'm just going to ask is, what do we do on December 1st? We find out that we weren't opted out. What do we do? I feel like I'm hanging on a ledge, and it's not what I feel like doing for 6 weeks period, right? There's got to be a better system. I know you're concerned about it, but I want to know, what do I do come December 1st? If I find out, and I assume I find out by looking at my Medicare chart, or I don't even know, because I assume my Medicare won't show that until January 1, when the change happens. How do I find out where am I going to find that out? And then what do I do about it?
Yeah, boy, if you have not received anything by the end of November, and I think this applies to everybody, immediately get in contact with the PSC. Because this is something that the union really will need to move on. In terms of dealing with the city, and we'll run interference with you with OLR and the Alliance. Hopefully it doesn't come to that, but yes, you reach the end of November, it's December 1st, by all means.
And we should be getting, okay. Will we be getting an email? How are we going to find this out?
Good question.
Okay.
Supposedly, the city is going to mail us, but I don't know. And of course, this is the anxiety that we're all going through, and I'm going through it too.
Yeah.
Because we don't have a lot of answers from the city. And this has just been a horrible process that we're being put through. But I don't know if I can say more than that. But the union and the welfare fund are there to fight for your interests. And if there's no satisfactory answer by the end of November, I know that's a long time to wait.
Yes.
We will certainly move on this issue.
And the other part of that is, I know there's a transfer period in terms of what you can, move in and out of these Medicare programs. Would December 1st exceed our transfer period in terms of the laws? I assume we were initially told it would be October, the end of October. That's why I made a mistake and said November 1st. It seems unconscionable to make this the end of November, right? When we were initially told it would be the end of October. Does that exceed the time at which we can deal, with the transfer options we get through Medicare, through government Medicare? So that's, obviously I have some real, I'm sure, I know I have good company on this one, but there are legal issues that have to be addressed.
Right. We'll address them. And yes, I mean, the issue of confirmation is one that's affecting a lot of people who want to opt out. So we will follow up on that. I mean, the one thing to remember is, yes, there's the transfer period this year. There's a transfer period. I mean, it used to be every other year. I mean, correct me if I'm wrong, Donna, but now there's going to be a transfer period every year. And you also have that once in a lifetime option, which evidently, and again, correct me if I'm wrong, you can exercise at any point, you know. So on January 17th, you want to opt out, whatever you're in, and join another plan. You know, the city does give you that once in a lifetime opportunity. So that's important to remember.
Okay.
So Sandra, I'm gonna move on.
Okay, but I have just one more question about this,
Sure.
this payment. How do we know whether the money is being taken out? You said that, I guess, Empire, we get some notification. Is there some way where we can check through TIAA if they are deducting that amount from our account, or however it works? How do we actually check ourselves whether the senior care is being paid for?
Dean or Bonnie? Yeah, Bonnie, go ahead.
I think you may have noticed that on the 21st of the month, before there's a change in your deductions or a change in your annuity, you get a letter from TIAA. If you're not receiving it through the mail, then you're getting it electronically. But it happened 3 times this summer that they changed the deduction for the $1 premium and went from $1 to $2 to 0, or vice versa. So I would imagine that before January 1st, you will get a letter from TIAA saying that your premium, that there's going to be a change in your premium deduction. And that's how you'll know.
Thank you.
There are also, we've heard from not only OLR, but we've also heard from the plan that there's a lot of built-in flexibility between now and January about the opt-outs, because they know that there's going to be a lot of changes and there's going to be a lot of issues about people in the plan. So I think that between now and then they know that there's going to be issues. So I wouldn't be as concerned about that from this point on. So I think we can be pretty certain that we should be able to push forward and make sure people have the ability to change their plans between now and then. So if the opt-out fails to go through, we'll have a lot of ammunition to be able to get it changed without using your one-time health insurance change.
Okay,
because of all of this.
So Donna, Patrick, Bonnie, and Dean, and I don't know, is Debbie Bell on this call or not, but can you stay another 10 or 15 minutes, or?
Yeah.
Because we still got lots of questions, and anything that's not answered, put your question in the chat. We have the chat from our September meeting. We have the chat from the August 30th information session, and we've been sending those questions to both OLR and the Alliance, and we will post responses on the website. So Bruce Brown, go ahead.
Yes, thanks very much. Thanks for taking, my turn. I really value this seminar, this web seminar. I have a question concerning comparisons between plans. The Advantage plan is attractive to me in one respect, in that it covers overseas medical expenses, and I find that relevant to me. But I am still concerned, excuse me?
It's emergency. Don't forget that. It's just emergency overseas. Don't fall into a trap. It's overseas emergency.
How is that defined?
It's emergency. Anything that comes up unexpectedly. It's not, if you're going to the doctor for a cold, or you're going to the doctor because you have some type of a chest, they define it as an emergency. So
okay, well,
that's
still
yes,
coverage,
it's coverage that you wouldn't have had for sure.
Right,
but
Yeah.
You know, you fall
I
down and
mean,
break your arm, so just,
right. Yes,
you know.
indeed. Okay, that's worth it for me. I mean, the GHI plan that I currently have does provide for some overseas coverage, but it's at 1988 out of network rates, and it's meager. So
Okay.
I'm happy to see this, but I do have some concerns about comparison between the current plan and the Medicare Advantage plan. And I'm concerned about how I would make that determination at the end of the year or next year when I might want to make a decision about whether to stick with the Medicare Advantage or not. So, for example, I pay little or no copays for a doctor's visit, but for lab tests, I do pay copays, of course. So for EKGs or other kinds of lab tests, I do pay a copay. And I'm wondering whether or not these kinds of things will be covered as they are now. And is there a way of comparing the two? In other words, is it possible for me to find out when I'm on the Advantage plan, whether what I'm paying for lab tests under the Medicare Advantage plan is more or less than I would have paid under my current original Medicare plan plus senior care? Will those kinds of comparisons be available, do you think? Or is that asking too much?
There was the comparison plan was out there, and they're the same. It should be the same. They're Medicare regulated. So no, Pat, correct?
Yeah, there's
I
a
mean,
comparison chart.
The only
that
thing that's
should
different
be part
is
of it.
that the only thing that was different is that these are all the only thing that changed July 1st is the copays that came into place also are coming into place into play for GHI. So there were no copays prior to July 1st. They did come into play for Medicare Advantage, and they also came into play for GHI. The only thing that GHI does is pay for the 20% that Medicare B doesn't pay for. Medicare Advantage is doing exactly the same thing.
So those copay, those should be identical.
So those copays should be the same in the Medicare Advantage plan as they are in the GHI plan.
Okay, I guess
Now
I'm
the-
informed. Yeah.
Now now if you go in network, there is a difference because there could be those prior authorizations which you would not be familiar with, because the GHI plan does not have those prior authorizations.
Right.
If you go out of network, you wouldn't have those prior authorizations either. So those are the differences between the two plans. But there is, do we have the comparison on our website, Pat? Do we still have those up?
We link to the comparisons on the OLR page.
There's a comparison on the OLR page between the GHI plan and the Medicare Advantage plan that should go step by step. So you can look at those and compare those and see. But that's the only difference between the Medicare Advantage plan and the GHI plan. So you can look at them and see what you think would fit better for you. It's up to you.
I guess I'm just concerned because of Len Rodberg's comments and Barbara Caress's mentioning of the fact that the contract hasn't really been finalized and we really don't know everything. We don't know what we don't know. I don't know what I don't know. And I'm just a little bit concerned that there may be costs that I don't anticipate under the new Medicare Advantage plan. And I'd like to be able to evaluate those during the subsequent year when those costs may be incurred.
I don't know what I'm not for Medicare Advantage. I'm not against it, but it's a PPO plan.
Okay.
So it's
I
only
don't want to
paid-
take up any more of your time, but I think you've
I don't
answered
know.
my question.
I would look at the. I don't know.
I will. I'll look at the comparison page. Thank you very much. I appreciate
You're welcome.
We move on to Francine Egger-Sider, who I believe is a new retiree.
Yes, since September 1st. You guys are doing a terrific job. I have a quick question. It's probably been covered, but I can't find it. If we opt out, do we still get reimbursed for the senior care?
You don't get reimbursed for senior care. You get reimbursed for your Medicare Part B premiums that you pay for out of your Social Security. That's what you get reimbursed for.
Okay, so you still get that if you opt out.
Yes.
Okay, now I'm her husband. Gerald Sider. I have a quick question. I retired 15 years ago. I've been, since that 15 years, I've been a dependent on Francine's plan, on my wife's plan. She wants to opt out. I want to stay in. Is that possible?
No.
No. If she opts out,
Do what she does.
if she opts out,
That's
the whole
great.
family opts out. If she stays in, we all stay in, huh?
Yeah.
Even though I once had my own,
But you don't now.
I once
Are
had my
you,
own.
are you a city, were you ever a city employee?
I was a CUNY professor for 37 years.
Oh, then you can opt out. You just have to get the coverage back under your own name.
Right.
You're allowed to do that.
And I'm allowed to do that.
Absolutely.
I would just go to my HR and then my college and get, I would get HR from my college to put me back on the CUNY plan.
Yes.
And the health.
Actually, I think you can go to OLR and probably all you have to do is reactivate your coverage, and then you have your own coverage, and she has her own coverage, and you can positively have your own coverage back, and you can.
Wonderful.
And you can do it.
Thank you.
You should do it
Debbie?
through the college HR because
Do it
they
through the
are
college
ones who
HR?
turn on the switch. Yeah.
Okay, so Debbie knows better than I do. Yes, then you could do that. You absolutely can.
Okay, thank you.
Why don't we go to Allison Rice?
Okay.
Hi, yes, actually, you answered one of my questions, so the only one remaining is when it does say, we've read the booklet very carefully, that they will pay the Medicare when we're living in Florida now. So I was concerned about doctors in Florida. The Advantage says it will pay the Medicare price, but it doesn't say it will pay the extra 20% that right now GHI is covering.
Absolutely it will.
Oh, that was the question. Okay, now if you go to an out-of-network doctor and he charges $1,000 and Medicare says, okay, 500 would be covered. And he says, okay, we'll take whatever, I'm just saying, he then wants to bill me for that extra 500.
If you go to a Medicare doctor, they have to accept the Medicare fees. They are not allowed to charge you more. It's against CMS.
Okay,
So
even if he's not in the plan, as long as he takes Medicare, he can only charge the Medicare fee.
Yes.
But he's not in the plan.
That's what a PPO is. It's a participating provider. So as long as he's a participating provider and he accepts Medicare, he has to go along with the Medicare regulations.
My husband is going to ask
Can
this
I,
question.
let me clarify a little bit of this question. If the doctor normally bills a large amount, which Medicare then cuts down to what their approved amount is, that's how we see it all the time. So, but when you go to an out-of-network doctor who says, I don't want to participate and accept this plan, pay me directly, the booklet says we're supposed to pay him what the Medicare charge is and get reimbursed from the plan. But is the doctor going to take that as opposed to, how do we know what the doctor is going to demand up front? And what if the demand turns out to be more than what the Medicare approval would ultimately be?
Medicare is very different from other insurance companies. Other insurance companies can say, I will accept assignment, I will not accept assignment. They can do all kinds of different things. You can't do that with Medicare. Medicare, the federal CMS has very different rules about accepting Medicare and being a participating provider. They cannot do that. Actually, there's all types of forms that you would have to sign and saying that I'm very aware that this is a doctor that does not take Medicare and that I will be responsible. You have to sign all these types of documents that say you're well aware of that. So you would know if you were going to that type of doctor. So if you're going to a Medicare doctor, he can't charge you more than the Medicare allowable amount. So there is no such thing as $1,000 and you'd have to pay $500 more. That would not happen. It can't happen with Medicare. It's just not that. It's totally different than the other types of insurances that would happen with. So that would not happen. Yes, there is a type of in-network and out-of-network provider with the Alliance's insurance, but you don't have to worry about that. If you want it, all you need to know is if you are going to see a participating provider, participating Medicare provider. That's what you need to know when you're going to find your doctors in Florida. And then you need to see, then you would get in touch with the insurance company. And I know I keep saying Alliance, but I don't think that's what Medicare, New York City. And the only reason it's New York City, it's because of retirees. You just need to check back when you get your cards and find out how the doctor gets paid, because you don't want to get caught in a tangle of who pays what. And then you'd work it from there. So whether you would pay the doctor first and get reimbursed from the Medicare Advantage Plus, that's the information that you would need from that point on.
Okay, but the other thing was about the various tests that an out-of-network doctor would require. He needs that was the case. We read the booklet carefully. We have to make sure that he gets pre-approval.
The way that it was described, and I kind of get caught up in like advocating for the Alliance program, but I'm going to explain to you the way it was explained to me. Right now, when you use your GHI senior care and they send you, say, for an MRI, they give you your prescription, you go for your MRI, you don't know anybody, you book it, you go for your MRI. What happens after the fact? When that bill is submitted to, and it probably goes through GHI actually, goes to submitted, sometime there is a small occasion when who's ever doing the processing for Medicare, they could actually kick it back and deny it. And whether you know it or not, you could be responsible for that. And actually have it sent back, and you could be responsible for payment. What Medicare Advantage plans are saying they're doing is they're getting it pre-processed ahead of time before you actually go, to make sure that there's no way that would ever happen. So they're getting that authorization done before you even go to make your appointment, so that there is no chance that would ever get kicked back and you'd have to pay for it.
Okay, so before the doctor gives us the script, if it's a participating doctor,
if it's a participating doctor, they're doing exactly what GHI has done all along, just giving you the script and you're going and getting it done.
Mm-hmm.
So 9 times out of 10, or even more than that, you're probably going to go have it done and there's no problem.
Okay, and I think one of the questions that somebody asked earlier, our first speaker, Barbara Caress, said that the out of New York was, the network was empireblue.com. That's what I wrote down.
That may well be, but still, you're in a participating provider. You don't need to know that. All you need to know is that you need to see a Medicare provider.
A doctor that accepts Medicare.
Yeah, you don't need to know that. All you need to know is that you're going to find a doctor who takes Medicare. That's all you need to know.
Thank you very, very much.
All right. Okay. We're going to do just 2 more questions. Others should put their questions into the chat. Sandy Cooper and then Hyman Shookman. Sandy, you're muted.
Is it working now?
Working now, Sandy.
Yes. This is on behalf of a colleague's widow, a friend of mine. She's not able to handle anything at this point by herself. She is receiving the benefits that her husband had when he was a faculty member at John Jay. And I'm trying to advise her about what to do, and I absolutely don't know what to tell her. Did you not hear me?
Yeah, we heard.
Oh.
I don't know how she gets her benefits. Is she a survivor? I don't know. Did she cover her
she's-
benefits? I have no idea.
She gets his, whatever he had, she has.
As far as I know, the benefits cease when he dies. So I have no idea unless she's covering her benefits somehow. And again, I thought you only had like 30, maybe 36 months. I mean, how long has he been
Oh,
dead?
no, he's gone much longer than that.
Sandy,
I'm
was her husband a uniformed officer of some kind?
No, he was an academic.
He was an academic, okay.
He was a member of the faculty for
Okay.
very long. I thought she told me she had some kind of medical coverage from him, as a widow.
Sandy, I
She
really,
could be very confused. I'm at this point. I will agree to that.
She should probably call OLR. I have no idea.
Okay, well, thank you.
yes.
I don't know what to do.
Last question or questions? Hyman Schuchman, are you unmuted?
Looks like he left the room.
It looks like Hyman's not there. So one more question. Carol Rivera Crone. Is Carol not there either? Well, then let's go on to Inez Martinez.
Thank you. I'm concerned about the pre-authorization. If it were refused, could one then use the one-time switch to get back to Medicare and not need it for say a major MRI or CAT scan?
If that were the case, you could, there's so many different ways you could go for appeals. I wouldn't think that would be a concern. There would really be, that wouldn't be a concern. If I haven't heard of anything, there's so many other avenues that you could go down if you needed an MRI or a CAT scan.
But I'm afraid of the delay. I'm afraid of the delay in trying to appeal or find another.
There are things called urgent delays that they have to respond to within, sometimes 24 hours, 72 hours. So there are different things that would address that, especially under Medicare.
Especially under Medicare, not under the Advantage.
Medicare Advantage has to do things under Medicare regulations.
Okay, thank you.
You're welcome.
Yeah, I do believe there are certain time limits written into the law, as Donna says. So I know other people have, important questions, but we, kept people here till what, 3:35 almost. So we're going to have to close it out here. I think this will be our last information session, unless, we find from our members that we need another one. We'll schedule another one. But I want to thank everybody for their patience. I want to thank Samantha Sherry, who staffed this meeting. And hopefully it moved relatively seamlessly. We covered a lot. I know there's probably a lot that we didn't cover. Lots of questions, lots of anxiety. We will continue to be on the case. And as I say, if necessary, between now and October 31st, we'll schedule another meeting. But if you go to the webpage that the Retirees chapter has set up, right at the top, it says, here's a process for getting your questions answered. And of course, the backstop for that is our own Patrick Smith. But go to the OLR FAQs, go to the Alliance toll-free number, go to the Welfare Fund FAQs. If all that fails to answer your question, our final backstop is Patrick Smith. So we'll try to post on the website more information about this kind of Rube Goldberg process of how people who are in TIAA get informed. I mean, you know, there are just many different parties there. OLR has to inform CUNY, and CUNY has to inform TIAA, and so forth and so on. But we'll post as much as we know. I mean, what we do know right now is that direct payment can be arranged. What we do know right now is you might get a bill maybe in March for 2 months if your annuity doesn't cover, you know, the payment for your New York City senior care. You'll then have what, through April, you know, to pay up. When we get more information, we'll put that on the website. If on the legal issues we have more information, we'll put that on the website. I just want to remind you that we do have a number of events coming up. Dave Kolochuk talked about the Some of Us book series. We have the meeting on October 20th for members, retiree chapter members only, on the Palestine-Israel, controversial Palestine-Israel resolution that the PSC passed back in June. We have a regular chapter meeting the first day of November, Monday, November 1st, on policing and alternative forms of policing. And on Monday, December 6th, we have a chapter meeting on the changing political landscape in New York City, where we're about to have a new mayor and a new city council, and New York State, where, of course, we now have a new governor. So we'll try to, as best we can, keep on top of this anxiety-provoking issue for all of us. You know, the decision that we have to make between now and October 31st, and we'll try to get your questions answered. And we'll put a video of this meeting, and maybe, well, I shouldn't promise that we'll put a copy of the chat up, but we may do that also. But there will definitely be a video of this meeting that'll be on the website in another day or two. So I want to thank everybody, and we'll see you hopefully next month. Take care. Bye-bye.
Thanks, Bill.